The live webinar is being broadcast. Please note that this call is being recorded. Welcome everyone. Today's webinar will last 60 minutes, and at the conclusion, the presenters will be answering your questions. To submit your questions, simply use the Q&A icon on the lower left corner of the screen to type your question or comment. Please note that this webinar is not eligible for CLE credit. If you are experiencing technical difficulties with the web portion of today's program, please email educate@americanhealthlaw.org or call us at 202-833-1100. Today's program is titled 2020/2021 Provider Compensation Lessons for Today and Tomorrow. A special thank you to the sponsor of today's program, HSG. Now I will turn the presentation over to our first presenter, Neil.
Thank you, Julia, and thank you to AHLA for working with us and presenting today's webinar. So as we get started here, I think first we'll kind of introduce ourselves. So I'm Neil Barker, a partner with HSG. Been with the firm since 2001. So pretty much since the founding of the firm, which means that in my time here, I've been involved in pretty much anything and everything that we do. You can see the 5 buckets of services that we list there. In my time, we've worked with hospitals and health systems, but also independent practices, though less of independent practices these days. But pretty much 90% of my time these days is focused on physician compensation. And that means compensation redesign, working with new compensation offers, working with hospitals and health systems on existing offers. And then obviously a lot of fair market value and commercial reasonableness services, which I lead for our organization. And so presenting with me today is Beth Simpson. And so I'll let Beth introduce herself real quick, and then we'll get started.
Hi, I'm Beth Simpson, and I'm a senior manager here at HSG, and I've been with the firm a little over 8 years. Prior to that, I've got some experience in healthcare delivery settings ranging from private practice to an academic medical center. And while at HSG, my focus is pretty split between compensation and fair market value and also operational improvements within practices.
Thanks, Beth. So, the agenda for today. So, first I'm gonna turn it over to Beth here in a minute, and she's gonna kind of review some of the external environmental factors that are affecting provider compensation, contracting with physicians and advanced practitioners, and then obviously the fair market value determination in 2022 and beyond due to those environmental factors, which we've highlighted 2020's COVID pandemic and the impact that it still has on all those issues and fair market value determination, and then 2021's Medicare physician fee schedule changes. So we'll ask Beth here in a minute to talk about those, and then I'll lead us through a discussion of organizational response to those environmental factors. We work with hospitals and health systems and physician networks, and obviously as we talked about, redesigning physician and advanced practitioner compensation, but recently, working with organizations and helping them respond to particularly the Medicare physician fee schedule changes for 2021, and responding and redesigning the compensation structure to adapt to it. And then we'll talk about potential approaches to fair market value determination despite the challenges that we will have talked about, and then recommend approaches that we think are best and highlight what areas we think are problematic. And then finally, we'll wrap up with offering 7 lessons that we feel that we've learned, coming out of the still living with the COVID-19 pandemic, and then the impact and what we learned from the change that CMS brought to us through the 2021 Medicare physician fee schedule change. So as we get started here, as I mentioned, Beth is going to talk about the environmental changes. Again, the first one being the impact of the COVID-19 pandemic and how that really affected the survey data for 2020. And so, looking at the 2021 surveys, which are based on the 2020 data, how that affected our interpretation of that data and how we use that data and some of the problems with that data. And then what's happening going on right now for many specialties, the change in the 2021 Medicare physician fee schedule really impacted because of the increased values placed on E&M codes in terms of their work RVU value. And so with a lot of specialties, particularly in primary care and medical specialties, because E&M codes are a significant portion of their overall CPT or visit or production potential, have really been impacted. Their work RVU production has really been impacted by the change with the 2021 Medicare physician fee schedule. And then after Beth talks about the environmental challenges and changes, I'll talk about the organizational response, what we're seeing organizations do, and how that's going to affect how we evaluate survey data, and it's going to affect the survey data in the future. And so we'll talk about that organizational response, all of which, bottom line, is affecting fair market value determination, which is never been easy to begin with, has been made even more challenging. So with that, I'll turn it over to Beth to talk about the environmental challenges and changes.
Thanks, Neil. So as we talked about, artificially high median comp per work RVU, it's always nice to put it into perspective and see real life examples. So on these following 3 slides, you'll see 3 different specialties that we've pulled from MGMA based on the 2020 survey report, which represents 2020 data. And so when looking at the impact of COVID-19, you can see in the far left, the median total compensation trend has increased pretty steadily. And from 2020 to 2021, it was a 3.9% increase. And then you can see in the middle box, the median work RVU trend, and it stayed fairly steady between 4,800 and 4,900 work RVUs from 2017 to 2020. But then you can see in 2021, specifically for family medicine, it went from 4,900 to 4,300, so 11% decrease in those years, which then in turn affects the median compensation per work RVU trend that you see in the far right, where it increased about $1 per year from 49 to 52 in 2020. And then because of the total compensation continuing to increase and the median work RVU decreasing in that year, the median comp per work RVU for 2021 was 59.69, which is a 14% increase over 2020, which makes things very challenging. And you can see on the next slide, so that's sort of an extreme upward tick. And then you can see this is sort of a status quo with nephrology where compensation continued to increase. It was about 4.1%. Median work RVUs decreased slightly at 3.9%. But in general, the compensation per work RVU only increased 3.6%. So the increase wasn't as drastic as it was within family medicine. And then if you look at the next slide, and this is the extreme opposite end of the scale when you think about critical care and their impact on the COVID-19 pandemic, you can see in the far left-hand side, their compensation continued to increase slightly at 2.6%, yet their median work RVUs, instead of decreasing, they actually increase at a rate of 4.3% over 2020, which in turn decreased their median compensation per worker RVU as reported from $96 in 2020 to $89.76 in 2021, which actually puts them back in line with 2017 and 2019 reported values. So it varies greatly by specialty, but you can see based on this, the wide range of compensation per worker RVU jumping at was $7 increase to a decrease, and then also sort of maintaining what has been historic. And then if you look on the next slide, you can see based on 71 reported specialties in MGMA and the median values for that. So on the top, you look at total compensation. Anything in green means it's a 5% or more increase over prior year. Anything in yellow is between a 5% decrease and a 5% increase. And then anything in red is a 5% or more decrease. So you can see in general, total compensation maintained fairly steady between a 5% decrease and a 5% increase. But then where the kicker comes in is on work RVUs, where you see that the majority of work RVUs sit there in the red with at least a 5% decrease over prior years, with the majority of them being a 10 to 15% decrease over prior year, which then in turn greatly affects that compensation per worker RVU rate, and it's shifting to the right, with now the majority being in that green of a 5% increase or a more than 15% increase over prior year. And where this particularly comes into play is we have some clients, which we have advised against, but they have compensation rates specifically tied to say the median compensation per worker RVU is what you'll be paid based on. And you can see this can become very problematic if you historically were paying them in 2020 $52 per worker RVU, and then in a matter of a year when the new survey comes out, you then pay them $59 per worker RVU, which can become very problematic.
Yeah, and I think too. I think if you look at the data, I mean, I think it when you think about it, it makes sense, given these specialties, and we highlighted some, that were different to show the kind of the varied impact by specialty. But if you think about family medicine, it makes sense, given the pandemic and what they had to deal with potentially closing office for a time, and not seeing as many patients being afraid to come to the office, trying to figure out how to learn, telemedicine and doing virtual visits, nephrology. People still need to get their dialysis. And so, there's probably less of an impact there. And then our pulmonologists or critical care intensivists, I mean, they're slammed, so all of a sudden their need has been escalated due to the pandemic. So the data makes sense. And we highlighted just 3 here, but there's a whole host of other specialties, as Beth highlighted here. Surgery was shut down, and so that affected anybody that's doing surgical cases, affected their RVUs, and so it's just simple math. If compensation stays stable but production goes down, that comp per work RVU goes up.
Yeah, so then if we switch gears and think about work RVUs and that impact, and then thinking about the Medicare physician fee schedule updates, and then coupling that impact. So there were several changes introduced in the 2021 Medicare physician fee schedule, as you can see. And what we'll focus on are a couple related to conversion factor decreasing. As you can see, from 2020 to 2021, it decreased 3%. And then from 2021 to 2022, it decreased an additional 0.8%. Moving it to 3461. And then when you think about the office E&M coding changes, things such as removing the 99201, time versus medical decision making, and other documentation and changes related, and the value in the work RVUs which you can see in this table to the right, where it lists the various some of the various E&M codes, what the worker VU value was in calendar year 2020, and then what that value became in 2021 and 2022. And you can see across the board, there were two codes that maintained with no increase. But for instance, 99212 went from 0.48 to 0.7, which was a 46% increase. So for some providers who are heavy E&M utilizers within their practice, not only are work RVUs increasing for the same volume of work that they have historically done, but also their conversion factors could also be changing if it's tied to a specific MGMA median or whatnot. And so, say for family practice, you automatically had to change from $52 to $59 conversion factor, and you're also paying an increase in work RVU values, because for the same volume, their work RVUs have increased just because of the values. So this can pretty significantly impact organizations.
And I think too, it's important to note too, I mean, we've talked about how the impact is different by specialty, which Beth will get into a little bit more on the next slide. But you can also see, I mean, CMS focused on the established patient visits. And so there's the recognition that there's more involved in seeing established patients. So the new patient visits weren't increased as much as established patient visits. So even within a specialty, given where a particular physician is in their practice, how many new patients they're seeing, the impact could be different. So it's not just specialty by specialty; it could be physician to physician or practice to practice, the difference in impact.
And so when you think about changes to the work RVUs, and we've had some clients who have providers who say, well, work RVUs are increasing, but you're also getting additional revenue. Well, to an extent that may be true, but the rate in which the revenue is increasing is not equal to the rate in which work RVUs are increasing. And so as you can see, pulled from this table, you can see various specialties as reported by CMS. And in column 3, the legislative impact, you can see the revenue percent changes expected with those legislative impacts. So in total, it's about 4%. But if you look at hematology oncology, it's a 13% increase in revenue. But then when you look at the fourth column, looking at the work RVU changes based on the Medicare physician fee schedule. So for that same specialty, looking at hematology oncology, even though revenue is planned to increase 13%, the work RVU values on average are expected to increase 19%. And so even though revenue is slightly increasing, it's not increasing at the same pace as work RVUs, thus leaving organizations to be left in the red if they don't make changes to help offset some of this.
Yeah, and I think it's important to point out too, this is just Medicare, so for most organizations, Medicare is a percentage, it's a portion of their overall revenue. Other payers are not making changes just because CMS did. And so those rates would stay the same. And so, the overall impact is going to be a fraction, as far as the revenue pickup is going to be a fraction of what we're presenting here.
Right. And so when we tie it all together, thinking about, key takeaways and considerations, first of which being patient volume being abnormally different in 2021 reports because of that COVID-19 pandemic, while compensation is, for the most part, maintaining pretty equally as it was prior, which in turn affects that compensation per work RVU rate and being able to benchmark that appropriately. And the fact that the work RVU adjustments are applying to all specialties, regardless of payer, whereas the revenue, as Neil was talking about previously, revenue increases will only be for Medicare. And so if someone has a high commercial payer mix, the increase in Medicare revenue won't be doing them as much favors if they had a higher Medicare payer mix, yet their work reviews are still being increased. And so it's threatening the financial sustainability of organizations, which then begs the question of how will organizations respond operationally, and then also how do we address the fair market value aspect of it, knowing that we rely heavily on reported survey data and making sure that we are aware of some of these key considerations and how it affects the report so that we can appropriately adjust for various aspects of it. And then, as we talked about before, having compensation, production, or bonus rates, or really anything tied specifically to the then current MGMA, AMGA, Sullivan-Cotter survey reports can be very problematic, as we've seen at some clients.
Thank you, Beth. And so that kind of concludes what we were talking about as far as the environmental factors and impacts and challenges, which for the most part are kind of almost, we could say, in the rearview mirror. The organizational response, though, is still going on, and we're still seeing organizations making changes and whatnot, particularly to the Medicare physician fee schedule. So this slide here is really in response to the COVID-19 pandemic, and I think it provides some background and some context that we've really already kind of seen in the data. But the question here, we asked organizations that we were working with at the time, organizations that we were familiar with and have a relationship with, basically asked them if they took measures to mitigate the impact on provider compensation due to the drop in volume associated with the COVID-19 pandemic. And so we surveyed providers in the summer of 2021 and asked them if they've taken measures. And you can see there that 83% said yes, they took some sort of measure to mitigate the negative impact on provider compensation. And I think, as we'll talk about and as we've seen, as Beth's data showed, compensation didn't change a whole lot. And I think this data kind of supports that. To the right, we asked those organizations that said yes, and what type of changes did they make? And obviously, this doesn't add up to 100% because people could choose, more than one. They could implement, say they're not going to implement salary reductions. At the same time, they can also pay, bonuses using pre-COVID baseline. So, but you can see here the results said that 57% said that they did not implement any salary reductions. So, if a physician was not hitting their work RVU targets because of ORs being shut down, office schedule being canceled, or being impacted due to the pandemic, they did not reduce base salaries if typically they would have due to not hitting production targets. And then others said that they paid production bonuses using the pre-COVID production as a baseline. So basically paying based on the trend they were on before the pandemic. Some paid total compensation, so salary and bonuses equal to what the physician earned last year. And then others, 14%, provided some other sort of supplemental bonus to make up the difference, what the physicians might be losing in terms of bonuses given the impact of the pandemic. So on this slide here, where we basically asked organizations regarding the 2021 Medicare physician fee schedule, if they had implemented the work RVU values that were a part of the 2021 Medicare physician fee schedule. And so, we again surveyed in the summer of 2021, and you can see here that 37% said that they had already implemented the values for the 2021 fee schedule. 22% at that point said that they hadn't, but they plan to within the next 6 months. And then 27% said that we probably wouldn't do it we plan to implement, but we won't do it within the next 6 months. So at some point they plan to implement the changes. And then only 15% said that they had no plans to implement the 2021 work RVU values at that point in time. Obviously that could have changed by now. More organizations may have said, yep, we're going to go ahead and adopt that. But based on the survey that we conducted, most were, either had done it or were going to in the near future. So this question is related to the response to the Medicare physician fee schedule. So we asked organizations what their selected rate adjustment philosophy was going to be. As we've talked about with the 2021 fee schedule, work RVUs are going up, revenues going up a little bit, but not as much as the rate of work RVUs. And it's only for Medicare that revenue would be going up. So we had a lot of organizations calling us, asking for help, which we provided and worked with organizations to figure out, what's the right approach, what's the right philosophy, what are the right adjustments to deal with the impact of the 2021 fee schedule. And so we asked the organizations what their approach was, and you can see here the results. So, the 28% basically said that they were going to have a compensation neutral approach, which, basically means that they're, saying regardless of what CMS has done with the work RVU increases, you're going to get paid the same as you did before for the same level of effort. And so they're going to make adjustments that basically hold compensation steady. And so if a physician saw 1,500 patients last year, and they see 1,500 patients this year, they're going to get basically the same compensation regardless of the work RVU increases from the 2021 fee schedule. 24% said they were going to make no adjustment. And so they're just going to let the rate stay the same and let the work RVU values flow through. And so basically in this case, compensation goes up the same rate as the work RVU increases. So if a practice or a physician sees their work RVUs go up 19% and they're on a work RVU based compensation model, compensation would go up 19% as well. So the next one, some organizations said it was going to be mixed within the organization. And we did see that a little bit. We had some organizations say that, we've been paying probably below market for our primary care physicians. We've been paying, $30, $36, $35 work RVU, somewhere in the 30s. We were going to have to address that because we were below market. Medicare's basically kind of taken care of that for us by increasing the work RVU values. So we're not going to make an adjustment there, but we've been right at market or better with some of our surgical specialties, and we do need to make an adjustment there. And so it has been mixed within organizations because of factors like that. And then you can see 14% said that they were going to take a budget neutral approach, which basically says that, we realize that we're going to get some incremental revenue from Medicare. And so we're going to make adjustments to our rates that reflect that. We're willing to pass along any of that incremental revenue, but not any more than that. We don't want to end up upside down. We want to end up in the same spot in terms of any subsidies or losses that we have in the group. And so we're willing to pay a little bit more, but we want to make sure that we're financially responsible and only pass on the incremental revenue amount to the physicians. And then 12% basically said they weren't sure yet. And then 6% had some sort of other approach. So this slide is one that we've actually presented when we're working through with organizations and trying to figure out that philosophy. So this slide is usually part of our overall management board or physician education. And basically lays out the kind of the spectrum of rate philosophies or approach that that an organization can take. And I've kind of talked about it on the previous slide, but basically kind of walking through it. So, the no adjustment approach on the left is, as I talked about, the rates would stay the same. So rates and targets stay the same regardless of the increase in work RVUs from the 2021 fee schedule. And for most organizations, it's a negative impact on the bottom line. They end up, spending more on production-based compensation than they were in the past, not getting much more in terms of revenue. So it ends up being a negative bottom line. The compensation neutral approach on the far right is the rates and targets are adjusted, just like I said before. A physician seeing 1,500 patients last year basically makes the same for those 1,500 patients going forward, regardless of the change with the Medicare physician fee schedule and the increase in the work RVU values. And so this, for most organizations, if they have this sort of approach, it would have a positive impact on the bottom line because of the incremental revenue from Medicare. And then in the middle, the budget neutral approach is what we talked about. We're going to adjust the rates so that any compensation increases reflect the incremental revenue that we're seeing from Medicare. And obviously, an organization, this is kind of an oversimplification, but an organization can be anywhere, on that spectrum of adjustments. So the next few slides are basically just kind of numerically adding some numbers and some data to the philosophy that we're talking about. And so we kind of create an example, and it's really been helpful in walking through with organizations, and particularly with physician groups, kind of walking through the numbers this way to kind of help them, understand what we're talking about. If we're coming to them and we're saying, hey, we're going to have to make some adjustments to our bonus factors going forward. And we just want you to understand what our philosophy is, our approach, and potentially how that's going to impact you. And so we start with this example of a physician, an unnamed specialty physician producing 5,000 work RVUs, generating a total of $375,000 in revenue, 125,000 of which is coming from Medicare, and 250,000 coming from other payers, commercial and self-pay and so on. That physician is paid at a rate of $50 a work RVU. And so at 5,000 work RVUs, they're earning $250,000 a year. And so on the right, the practice impact summary, we're taking the revenue that is coming into the practice, subtracting out the physician's compensation, and showing that we have $125,000 of contribution that would go to paying benefits, paying for the overhead and the operating expenses in the practice. So as we've been confronted with the 2021 Medicare physician fee schedule, an organization might look at it and say, doing the analysis, with the change, looking at CPT for CPT, but just changing the work RVU values, this particular physician would see a 15% increase in work RVUs, just as we say, from flipping the switch to the 2021 fee schedule. Those 5,000 work RVUs would go up to 5,750 work RVUs. Now we would see a 10% increase in Medicare payments. And so that 125,000 we were getting from Medicare becomes 137,500. We're status quo on the commercial reimbursement at 250. So our total revenue is 387,500. And so most organizations we're working with are saying, okay, on that spectrum, kind of what's our philosophy going to be? And so the next 3 slides, just kind of looking at those adjustment approaches and what that might look like and what the impact might be. So again, we have basically said here, an organization that decides, nope, we're not going to do anything. We're going to hold steady on the rates. We're going to let it all flow through. we would see that, again, work RVUs go up from 5,000 to 5,750. We do have incremental revenue of 12,500, but we're also, because we're letting the rates flow through and the new work RVUs flow through, that physician's compensation goes from 250,000 to 287,500, which is an increase of 37,500. And so if we look at the practice impact on the right, where we did have a direct contribution of 125,000 in the practice to pay for benefits, overhead, and operating expenses. Now we only have 100,000. And so, we've got 25,000 less, which, maybe doesn't sound like much, but for organizations with hundreds of providers and physicians, any kind of number like that starts to add up. And for organizations that are already losing money on their practice, again, this can add up pretty quickly. And for a lot of organizations, it's not something that they can carry forward. And so making some sort of adjustment along the spectrum of budget neutral to compensation neutral is a lot of times where the conversation goes. And so the budget neutral approach would say that, okay, we're going to make an adjustment to our rates so that we're just passing through the incremental revenue that we're going to realize in the practice. So again, we flip the switch, and so the work RVUs go to 5,750. And so what we do is we do the math, do the modeling, and make an adjustment to that rate, which was $50 a work RVU. We adjust it down to 45.65. And you can see there that even though the rate is going down, the compensation for the physician is going up, essentially, at the same level as the incremental revenue that we're going to see in the practice. And so the contribution to the practice stays the same, so we don't increase our losses. But to the physician's advantage, that physician is basically earning 12,500 more on the same level of effort, the same level of volume. And so in a lot of cases, a lot of organizations look at it as a win-win situation, but it does require that education to say, hey, your rate's going down, but CMS has changed one component of that calculation, a very important component of that calculation, which is the work RVUs. We have to adjust to deal with that, and you're gonna see the benefit. Maybe perhaps not at the level of 19-20%, maybe what you've heard about your work RVUs going up, but you are going to see some benefit from the changes. And then lastly, the compensation neutral approach, again, we're going to make an adjustment, but as we've talked about, this adjustment is going to be a little bit more extreme and a little bit more to the favor of the group or the practice or the network. And so we're going to be a little bit more aggressive with our rate adjustment, and we're going to take that $50 a work RVU rate down to $43.50. And the physician really doesn't realize any of the benefit of the increase in Medicare revenue, earning still about the same $250,000. And the practice actually has additional dollars to put towards the overhead and the operating expenses of the practice. So, bringing this to a close here, we just kind of provided an example cautionary tale, because we do see organizations that, either, as Beth mentioned, contractually put, certain MGMA or other survey targets in their survey, in their contracts, or they tie those bonus rates to published comp per work RVU rates. And so, an organization that, was using the 2018 survey and probably before that had used previous surveys and were okay because there wasn't much change year to year, in the rate per work RVU. But in this example, an organization that's using that 2018 MGMA report and is using a $50 rate per work RVU for its primary care physicians, that primary care physician on average is producing 5,000 RVUs and as just in our previous example, would earn $250,000. But with the change in the 2021 data, given the COVID-19 pandemic and what we talked about before, that organizations kind of held compensation, constant. They mitigated the impact of the drop in volume due to the pandemic. They protected physicians from that. So you saw compensation staying about the same, but volume dropping. As Beth walked through, the comp per work RVU rates went up. And so an organization that ties to that particular rate, if they adopted the 2021 survey median rate per work RVU, they would basically have doubled down on the problem here, because they would see the increase in work RVUs, from the change in the fee schedule. So in this case, we said work RVUs went up 20% due to flipping that switch and going to the 2021 fee schedule. And so 5,000 becomes 6,000. And then if we're using the published comp per work RVU rate, we're going to now pay $59 a work RVU or $60 a work RVU on top of increased RVUs. And so, in this particular example, we would see a 44% increase in compensation for the same patient volume. And again, as we've talked about, without incremental revenue. And so really, as Beth mentioned, we really caution, against using published survey rates. We like to use surveys as a guide, but having them hard coded into agreements, into contracts, as we've seen, can be a problem. And so we just kind of caution against doing that. So key takeaways, and kind of wrapping up the discussion of the responses that organizations might take, given the environmental challenges that Beth talked about, is that, the work RVUs reported in the 2021 survey should, and we underline should, because I think it's going to be interesting to kind of see what the 22 surveys look like when they come out and how they're reported. Because as we've talked about, there are some organizations that have already adopted the 2021 work RVUs, but there's some that have not. And so how that's dealt with and how that's handled and how that impacts the surveys is going to be interesting to see when we get to the 22 surveys. And then, the second takeaway, due to CMS's E&M work RVU changes and the lack of corresponding increase in professional revenue, organizations have it already made changes, or they're going to have to. The economics of the environment is just going to require that they do so. The response is going to vary from organization to organization and specialty to specialty. And so again, that's really going to be interesting to see how all that bears out in the surveys. And then organizational response will, as we've talked about, will impact survey data going forward. And so it's really going to be interesting to see. And so lastly, in determining FMV in 2022, we have to consider, in our approach, we have to consider all these factors. We have to consider the impact of COVID. We have to consider the work RVU changes. And then we have to consider that organizations are responding to it. So it might be 2023 before we have really reliable data once again, given all the changes that we've dealt with over the past couple of years. So as we come to talking about, FMV approaches and dealing with the challenges that we've talked about, we thought it made sense to kind of talk about some general standards that we typically have as it pertains to fair market value determination. And so generally, and we realize that, there's not a safe harbor. And I think that CMS was pretty explicit in the latest round of the Stark regs, that there is no safe harbor and that there's nothing magical about the 75th percentile, that each situation is unique and case by case and all that. And I think that definitely is true and factors into how we approach fair market value. But generally, as kind of default, we do, kind of use that 75th percentile as, kind of a guide, and particularly for guaranteed compensation, we like to have a standard that says that generally, guaranteed compensation, so base salaries and guarantees are going to be, below the 75th percentile unless, exceeding that level is warranted by extreme or unique circumstances. And if that's the case, then we're going the extra mile to justify and document why that's the case. And then as guaranteed and total compensation moves up the percentile scale, especially it becomes more acute, as we approach and then pass the 75th percentile, we like to see more, compensation to production alignment. And so again, further you go up the scale, the more you would like to see alignment of compensation and percentile, again, unless there's unique circumstances that we need to document. And so at the 75th percentile and above, we're typically okay with production percentiles exceeding compensation percentile. I mean, that's at any level, that's typically, something that we feel is, and most organizations feel is okay. We're okay if production is higher than the level of compensation. And most of the time it makes sense financially because of the cost of practices, the cost of benefits, the economics of the market. It just, having perfect alignment can be expensive. Compensation percentiles and production percentiles can match. That would be a kind of a perfect world. If somebody's producing at the 65th percentile, for example, they're earning at the 65th percentile. We're typically okay with that as well. Again, market by market determination and perfect alignment can often be expensive, but from a fair market value perspective, that's typically okay. And then compensation percentiles should not exceed production percentiles by more than percentile points, again, unless there's warranted or unique circumstances. And then, when using published compensation per worker review rates, this is an area where we see organizations, kind of make mistakes because they rely too heavily, and sometimes they get pushed by providers that say, hey, I'm a median or I'm a 75th percentile physician. I should be getting paid a median or 75th percentile rate. But one couple of things that we need to keep in mind with those rates is that they're not published, bonus conversion factors. And they're also just the product of the math. So one, they include all sources. It's total compensation divided by the work RVUs that are produced. So it includes all sources of income for that particular physician, not just their clinical services, but it could include call pay, could include medical directorships and any other sort of sources of income for that physician. So they're not published bonus conversion factors. And so you need to keep that in mind. And so we typically like to see those, if we're going to use those published comp per worker review rates, a good bonus conversion factor is typically going to be around the 25th percentile or less. Sometimes, in certain specialties, in certain markets, it perhaps can approach the median. But once we get past the median, it's and push towards that median, it really becomes a question. Is is it sustainable, at that level? And are we going to have misalignment going forward, and where we're exceeding some of the other requirements that we just talked about? And then we always like to use recent multiple data sources. I know a lot of people like to rely on MGMA, which kind of tends to be the gold standard, in which we rely on heavily because it's a great survey. But keeping in line with Stark recommendations and guidance, we like to use multiple data sources when we're doing our benchmarking and doing our fair market value determination. And then lastly, complex arrangements, so arrangements that have multiple sources of compensation coming in. We like to make sure that we're where we're needed, we're getting a third-party opinion. And then potential approaches to fair market value determination. So the bottom line here is basically just using the 2021 survey as it is not a good approach. Given the challenges that we've talked about, just using that survey, given the impact of the COVID-19 pandemic, particularly on the relationship between compensation and production, is not a good idea. And so the other options that we've laid out here are using the 2020 survey, and then compensation from the 2021 survey we think is okay to layer in here, just because there's not much difference. So looking at both of those we think is okay. And adjusting for the 2021 production impact, so taking the 2020 reports and then adjusting the production and data to account for the increases in the 2021 fee schedule is a decent approach, and probably ought to be part of maybe the multiple data points that you look at. But I think that what we wanted to highlight is that doing that by itself might lead to some issues, that it could lead to kind of an over estimation of what organizations are doing, because if you're just adjusting the production, as this particular slide shows, and you do nothing to the compensation, you've basically adopted a compensation neutral approach. And so that might be too extreme on the downward side as far as the relationship between compensation and production. On the other end of the spectrum, if we do nothing and just let the rates stay as they are and let the rates flow through and the work RVUs flow through, that might be too extreme on the other side of the spectrum, and overestimate the level of compensation. Because again, organizations are making changes. And so we think that the reality is going to be likely somewhere in the middle. And the adjustments, when all this starts to shake out, is probably going to be for most organizations, most specialties, is going to be somewhere in the middle of those two approaches that you see there. And so the reality is going to be somewhere in the middle. And so again, I think that has to factor into how we look at fair market value determination, and we just probably have to have more than just one data point, going forward currently, until we get into 23, 24, and then hopefully by that point, the data starts to kind of maybe normalize a little bit. So as we wrap up here, with our lessons learned, the 7 lessons that we'd like individuals and organizations to kind of take away, from the presentation is, contractually, don't, as Beth mentioned, and I've talked about a couple times, don't tie compensation rates or production thresholds to the annual survey data. There are inherent issues with this. But as 2020 and 2021 have shown, anything can happen in a 1-year snapshot in time. I mean, who expected a 100-year pandemic or the most significant changes to the relative value scale in the last 20 years? And so, again, the work RVUs are as much a part of the calculation of work RVU based compensation as the factors are themselves. And I think we've all become conditioned to focus on those comp per work RVU rates and those bonus factors, but the work RVUs are just as important in that calculation. Contractually, give your organization flexibility. We had some organizations that were really forced into changing because of how they structured their contracts. So, give those contracts flexibility and the organization flexibility to stay on specific work RVU tables so that you have time to assess and educate and then responsibly implement those changes, if CMS were to say, we're going to change work RVUs again in some form or fashion. And then educate providers regarding the value of the work RVUs themselves. Educate, and communicate with your providers and walk them through, the impact and the changes and particularly the values of the work RVUs themselves, because again, we've become so fixated on those comp per work RVU values. And then 4, stay away from the 2021 production survey data as far as the production itself, because of the impact and the kind of the distortion of the relationship between compensation and production. If adjusting production data, be careful that you understand that relationship between compensation and production, given the varied approaches that are going on in the market. And so you could do the 2 extremes that we showed, but perhaps some scenario modeling is necessary as well. If we're comfortable that work RVUs are going up 20% because of the responses, maybe comp is only going up 15, 10, or some percentage less than that. Challenges, number 6, challenges present opportunity. And so a lot of organizations have kind of embraced this and said, with all the changes going on, perhaps it's time to reassess our compensation-based incentives and make changes and start incorporating non-productivity or quality-based incentives, or right-sizing models that have historically been out of line or questionable. And then lastly, because of all the challenges and everything that we've talked about, we think it makes sense to seek the advice of an experienced healthcare evaluation expert.
And Neil, I want to emphasize the communication aspect of it, because we have some clients that in the height of the pandemic, they had daily calls with their providers to help them understand what's going on, what was closed that day, how's revenue looking, how is this going to affect our compensation. And those providers were really engaged. And while maybe some of them had reduced compensation during that time, they were also educated and aware of why it was happening. And those conversations and keeping them engaged throughout the process really helped their outcomes.
Yeah, very much so. Very much so. So I think we do have a couple questions. I think one question that we're looking at here is, what are unique circumstances that might warrant comp percentile 10% above production percentile? And there's a host of circumstances where that might be the case. So I guess some that come to mind, if somebody's providing extra services, if they're providing medical directorships at a significant level, if they're a specialty that perhaps is required because of, let's say, trauma call coverage or just to maintain the service line. Perhaps I think of heart surgery as being one we've seen in cardiac surgery, where maybe in the market we need 1 surgeon, but because of call requirements and all that, we've got to have 2. And so the volume is not where it maybe needs to be to support 2, but we have to have 2. And so in those cases, you might see a situation where, the salary requirements and the volume just don't match up. Other situations could be temporary. If a physician has gone, had to be out on FMLA, that would be a unique circumstance. And so there's a host of reasons that could be there. And hopefully that's given, some examples of what we maybe see occasionally. So another question, I think we've got like a minute left. Are you seeing significant variation in production and compensation differential by regions as a result of the pandemic, and how hard certain areas have responded and been affected? So I think we do definitely see some differences in the compensation to percentile relationship by region. Particularly, I think in primary care, it seems to be a little bit more local than with specialties, which tend to seem to be more nationally recruited. And so there is that variation that we see, and it does differ by location, by market. So I think that brings us to the end of the presentation. And if we haven't gotten to everybody's questions, then we'd be happy to respond to those, outside of this forum, via email or telephone call. So I guess we'll wrap it up here and turn it back over to Julia.
Great, perfect. Thank you both for your excellent presentation. And thanks once again to our sponsor, HSG. Once again, I will repeat, I did add it in the chat, but all live webinar registrants will receive a complimentary recording of this webinar. The recording will be available within 5 business days on the webinar page. Today's program is copyright 2022 by American Health Law Association with all rights reserved. This concludes today's program. Thank you all so much for joining, and thank you once again to our speakers. The live webinar will now be disconnected.